Thank you all so much for being here. This is our fourth Come to the Table event out of 4, and this is our new event series here at Henry Street. And it's an honor to host Dr. Uché Blackstock, who's the author of Legacy, A Black Physician Reckons with Racism in Medicine. And Dr. Blackstock will be speaking today with Professor George Aumoithe. Thank you so much for being here. So I know most of you in the room, or many of you. My name's Katie Vogel. I work here as the public historian at Henry Street. And yeah, many people in the room, most people are Henry Street staff members or team members from many different parts of our organization. Some people work here at 265 in our administrative headquarters, or in housing, or next door in our firehouse, which is our walk-in center, and our arts programming. I see people from lots of different programs. Also our community mental health program as well. So I'm going to read our speakers' bios so you have a little bit more context for their work, and then hand it over to them for their conversation, and then we'll do audience questions at the end for the last few minutes. And then we actually have the book for sale as well, Legacy, and it's for sale today by a local independent bookstore called You and Me Books. So we have the book right over here. You can come over at the end if you'd like to purchase the book and to get it signed as well. So Dr. Uché Blackstock is the founder and CEO of Advancing Health Equity, appears regularly on MSNBC and NBC News, and is a former associate professor in the Department of Emergency Medicine and the former faculty director for recruitment, retention, and inclusion in the Office of Diversity Affairs at NYU School of Medicine. In 2019, Dr. Blackstock founded Advancing Health Equity with the mission of partnering with healthcare organizations to dismantle racism in healthcare and to close the gap in racial health inequities. In its 5 years of existence, Advancing Health Equity has helped major companies and hospitals and health systems to create strategic plans for promoting equitable healthcare moving forward. And Dr. Blackstock received both her undergraduate and medical degrees from Harvard University, making her and her twin sister Oni the first Black mother-daughter legacy graduates from Harvard Medical School. Dr. Blackstock's generational memoir, Legacy, A Black Physician Reckons with Racism in Medicine, was published by Viking Books in January 2024, and she told me she's been on tour the whole entire year. That's a lot of speaking engagements. Thank you so much for being here. I know it's the last one of your entire year here at Henry Street. Yes. And this book became an instant New York Times bestseller. I just finished it, and it's really an incredible memoir. Dr. Blackstock currently lives in her hometown of Brooklyn, New York, with her 2 school-age children. And Professor George Aumoithe is a scholar of U.S. healthcare, comparative welfare, state history, and civil rights law at Harvard University. His research focuses on the effect of anti-inflationary economic policy and colorblind ideology in public hospitals, as well as the effect of fiscal policy on epidemic preparedness. His book manuscript is Medical Scarcity, the Resegregation of Healthcare in America. The project is a genealogy of the ideology of medical scarcity, how it has reshaped the nature of public healthcare, and why it has produced dire health outcomes for Black, brown, and poor people from urban and rural America. And Professor Aumoithe teaches courses in Black history, history of public health, and legal history at Harvard University, and just finished his semester, so I'm so glad you're here. All right, I'm gonna hand you the mic.
Thank you.
I'm so happy to be. Tech check. All right.
1, 2, 1, 2.
1, 2, 1, 2. We're about to cipher, right? I'm so happy to be in conversation with you, Dr. Blackstock. This book. Yeah. Okay. I'll call you Uche then. This book is so incredible. I think the way in which you braid your personal narrative with the larger societal forces that we so often kind of think of as impersonal is really quite revelatory. Like, all this is deeply personal. And, through your narrative, I think we can all maybe identify our own healthcare story. So I'm hoping today's conversation can be that we can kind of just range across this story and to think about the memoir and the way you put it together. And I know to start that you'd like to sort of situate us by reading an excerpt from the book.
Okay, sure. Do you want to read the poem first, or did you want me to read?
Oh, why don't?
Yeah,
oh,
do you want to read the
well,
poem
you know
first?
what? I can do that.
Okay.
I can do that. Actually, I think that's appropriate. So, as many of you may know, we have a new ancestor, Nikki Giovanni, who recently passed this week. A true scion of the arts and letters, of Black culture, of poetry, and so much of the book and legacy is about Uche's relationship and memory of life with her mother. And so, because I know that mothering, womanism, Black feminism was so central to Nikki Giovanni's life and work, I wanted to read a poem by her entitled Mothers, just to kind of bring her into the room. So we're bringing in both Uche's mother into the room, but we're also bringing in Nikki Giovanni into the room. Mothers. The last time I was home to see my mother, we kissed, exchanged pleasantries and unpleasantries, pulled a warm, comforting silence around us, and read separate books. I remember the first time I consciously saw her. We were living in a 3-room apartment on Burns Avenue. Mommy always sat in the dark. I don't know how I knew that, but she did. That night, I stumbled into the kitchen, maybe because I've always been a night person, or perhaps because I had wet the bed. She was sitting on a chair. The room was bathed, and moonlight diffused through those thousands of panes landlords who rented to people with children were prone to put in windows. She may have been smoking, but maybe not. Her hair was 3/4 her height, which made me a strong believer in the Samson myth, and very Black. I'm sure I just hung there by the door. I remember thinking, what a beautiful lady. She was very deliberately waiting, perhaps for my father to come home from his night job, or maybe for a dream that had promised to come by. Come here, she said. I'll teach you a poem. I see the moon sees me. God bless the moon, and God bless me. I taught it to my son, who recited it for her, just as so we must learn to bear the pleasures as we have borne the pains.
Thank you.
Yeah, thank you.
So I'm going to read about 2.5 pages from the introduction of my book, just to give you all some context and perspective. And thank you so much for that. When I was a little girl, my twin sister, Oni, and I used to visit our mother at work. Her name was Dr. Dale Gloria Blackstock, and in the 1980s and 90s, she was an attending physician at Kings County Hospital Center, one of the public hospitals affiliated with SUNY Downstate in Brooklyn, not far from our home in Crown Heights. Our mother worked long hours at her job, and so sometimes we'd head to the hospital after work to see her and do our homework. Walking down the disinfectant-scented hallways, our shoes squeaking on the linoleum floors, we'd make our way to the large, echoing cafeteria, where we'd pull out textbooks from our backpacks and settle down to work, alongside the physicians, nurses, technicians, and aides taking a break. The staff behind the counter knew us well, especially because we strongly resembled our mother, and would smile warmly and ask, "Visiting your mother today?" Excuse me. After homework was done, we'd sneak into her clinic to ask for small change to spend on our favorite red Jell-O. She'd hand it to us, and if we were quiet, let us stay and observe for a minute or two as she examined a patient. Our mother was warm but serious with those in her care. Occasionally, her face would reveal a smile, but more often than not, she was extremely focused on what they were saying and what was going on in their lives. She'd grown up in the same Brooklyn neighborhood where the hospital was located. The daughter of a single mother from New Jersey, raised on public assistance, she'd become the first person in her family to graduate college. And after graduating from Harvard Medical School in 1976, she'd return home to her community. At Kings County SUNY Downstate, she wasn't just taking care of her patients, she was tending to her neighbors. In her interactions with them, she always seemed to know as much about their children and families as she did about their respective medical problems. When you came in for a visit with Dr. Blackstock, you weren't only having your blood pressure or cholesterol checked, you were also meeting with someone who was going to assess how your whole being was faring. I believe our mother practiced what is now known as structurally competent and culturally responsive care, which means that the entire complex nature of the patient's background and the social context in which they live, work, love, and pray is considered during evaluation. And her patients loved her for it. She was always bringing home little gifts from them, a knitted shawl, homemade cookies, or cake, tokens of appreciation. My sister and I were only 19 years old in 1997 when we lost our mother to leukemia, and she was just 47. She died too young, but by then her influence had indelibly rubbed off on us. Our mother's passion for learning, her dogged perseverance, and her commitment to serving her community heavily influenced our own decisions to become physicians. Oni and I both graduated from Harvard University and then attended Harvard Medical School, the school's first Black mother-daughter legacy graduates. Like her, we both went to work with historically underserved populations after graduating. My sister at a hospital in the Bronx, while I went to train at Kings County SUNY Downstate in Brooklyn, following in our mother's footsteps. In the years since then, I have felt her by my side in so many of my own interactions with patients. Her ability to listen and truly care continues to be a model for me, and it's something that our patients are crying out for now more than ever. Thank you.
And so your memories of your mother's doctoring really structure this narrative. So sometimes we think about memoir as like an individual act, but I really felt like her spirit was with you literally every single step of the way. Can you kind of share with us a little bit what that experience was like? Like, what's your sort of subjectivity when you're writing that, when you're kind of constantly thinking of mom in a sense, but then also thinking about the way you differ, how Oni, your sister, differs, the paths that you took. Can you kind of share a little bit of that experience?
Sure, and that's why I often refer to the book as a generational memoir, because it's not just my story, but also my mother's story. And this was an opportunity to give her legacy a voice. So the book has, the legacy has multiple meanings. Obviously, it's the legacy of racism in medicine, the historical piece, the contemporary piece, but also, continuing my mother's legacy. A lot of the work that she did in our neighborhood in Brooklyn was with other Black physicians who lived and worked in the same neighborhood where they cared for patients. And so that's what I saw from a very early age. I actually grew up thinking that most physicians were Black and were Black women, because that was my reality. And I saw them, work in service to our community, holding community health fairs, and just, really having this strong commitment. And so that was my exposure. And so when I was writing the book, I just wanted to make sure that I paid, homage to my mother, all of these really brilliant, beautiful Black women that were, doing work that we call like health equity work now, and addressing the social determinants of health, as you all know, housing, education, transportation, doing all of that then when we weren't even sort of using those terms. And so I wanted to make sure I used storytelling and that my narrative to connect the dots for folks, to readers, as to why in 2024 we're seeing all the appalling statistics as it relates to health and health outcomes in our communities.
Yeah, and we can't give away the whole book. Please buy it. But
no, it's okay. I know you all will buy it after this conversation, whether or not we reveal everything or not. It's okay, don't worry.
But I wonder if you can give us a sort of synopsis or overview. The book is structured in 3 parts. Can you kind of share with us like what those parts are about, why you chose that?
Yeah, well, I really wanted to talk about, so writing a memoir is a very vulnerable experience because you're sharing your own personal story, and I wanted to share with people my own journey from child to medical student to resident to physician, because I had to unlearn and relearn so much of what I was formerly taught or not taught. So, a lot of the revelations, excuse me, that I make in the book are observations that I made like during my residency at Kings County Hospital. So when I was caring for my patients there, making the realization that like the disease and illness that I was seeing in my patients was not a manifestation of individual choices as I was taught about in medical school, but more of what was happening on a community level, systems level in their lives. And so, I talk about, some of the patients, I talk about this patient Jordan with sickle cell anemia and how, not only is he, I don't want to say victim, but victim of systems that don't exist to care for patients with sickle cell disease in our country, but also had to deal with being stigmatized on an interpersonal level by clinicians who thought he was drug seeking. So, but I didn't learn any of this, in medical school, right? So I really wanted, so it's, 3 parts, like, my childhood, my sort of my training, and then sort of coming into my own. I talk about, so I was in academia. I was in academia for almost 10 years. And that part was really important to talk about because part of the journey that I talk about is, I made this very painful decision to leave academic medicine because, and we can get into it, but because I felt I was undervalued and underappreciated and I wasn't able to do work in an authentic way. So that's why I founded Advancing Health Equity. But it happened around the time of the COVID pandemic, even before the pandemic started. And it's obviously still ongoing, but I wanted just to make sure that I talked about this journey that I took of unlearning and relearning and using that story to talk about these larger systemic issues.
Yeah, and I wonder, so much of the narrative takes place, particularly around your time in the emergency room. Can you kind of describe to us what life is like in an emergency room? I mean, I think we have like a sort of idea of it in like ER or like dramatization, but and obviously there are some moments like that in this book. But can you kind of take us into that world? What is it about the emergency room that people really misconstrue, and what should we know about and understand about it?
Well, I think for me, what I recognized about the emergency, so I was a first-year medical student when I had the opportunity to observe one of our instructors in the emergency department at Mass General Hospital, and I love this idea of being able to care for all comers, like you take care of everybody, and you see a breadth of cases from someone with a cold to someone with a collapsed lung to someone coming in with cardiac arrest, and that you're there for someone in their moment of need, right? But what I actually didn't realize, and I learned during my residency and as a practicing physician, that a lot of times, like what we see in the emergency department are people, unfortunately, who are not able to access preventive care. Right, we see that sort of the end result of a system that is not equipped to care for people in the way that it should, right? And so there is not a focus on preventive care. So, when I was at Kings County, I was actually seeing a lot of patients with end-stage kidney disease, with poorly controlled high blood pressure, with hemorrhagic bleeds, so bleeds in their head because the blood pressure, they weren't able to access the appropriate care they needed. And so I said in the book, like, the emergency department is where our social problems come to roost. And we know that when you access care through the emergency department, it actually is more expensive, right, than accessing care through primary care services, right? Like, we don't want people to get to the point where they need to use the emergency department. We know emergencies happen, but in terms of, for example, chronic diseases, gun violence, like these are issues that we can address.
Yeah, so in my work, medical scarcity, the resegregation of healthcare in America, I think about the sort of hubris of the post-60s moment that we've integrated everything and everything is fine and equitable. And what
Can you tell them about what happened in the 60s?
So in the 60s, well, in the 60s, we had Medicare and Medicaid pass, which was a big deal, right? I'm sure everyone's familiar with those programs. The first sort of government entitlement, federal government entitlement around healthcare provision, Medicare for those over the age of 65, Medicaid for those beneath, later, essentially beneath the official poverty line. And with this came a massive infusion of new patients into our public hospital systems and voluntary hospitals. But also with it came a sort of unforeseen anxiety about whether we had enough to go around. And so what you start to see after the 60s, after the sort of fall of de jure segregation, mandated legal segregation, was an evacuation of all sorts of specialty care into newer hospitals, academic medical centers, and suburban hospitals. And what was left in inner city communities was emergency care, essentially. So you pick up your career in the sort of wake of that transformation. By the time you start doctoring, it's sort of firmly established thing that I don't think everyone maybe would have been aware of historically, that there was much more variety, much more access, much more proximity to specialty care just 15 years before. And so what I found so fascinating about your narrative was how, one, you survived that shift, that sort of evacuation of resources, but also how that necessarily isn't a good thing. That's not a good thing. Like, resilience and grit in that frame should not be something we celebrate. That we shouldn't be celebrating that people are doing more with less, and yet we find ourselves in that situation. So
right, and I was talking to you a little bit earlier about Kings County, because you were born at Kings County. Yes, but my plan was, after I did my training there, I wanted to stay, but I write about in the book how I experienced burnout there, even just as a resident, because we had so little resources. Like, I remember some patients in the ER who I wasn't directly caring for would say, "Can you be my doctor, because I see you're doing everything for your patient?" And no, I was like, I was the phlebotomist, I was transport. No, like, I was taking my patients to CAT scan, because I was like, my patients, we gotta get this done.
You were doing a lot.
Yeah, I was doing a lot. But then there's like this toll that it takes on you, right? We were talking about the patient in the book, the older woman who asked me when she was getting her CAT scan, and I read about this patient who I'm so ashamed I snapped at her, because she's like, "When am I getting my CAT scan?" I'm like, I'm trying everything that I'm doing, but I found myself burning out, and that's the problem, and we talk about burnout as if it's like an individual issue, but it's a systems issue. And I felt so guilty about leaving, about not staying. But at the same time, I was like, I can't be a martyr. Like, I can't.
Yeah. And like, when you say that, I think about our audience. So many people are doing social work, or are sort of in contexts where they're connecting people to all sorts of ancillary care. So I wonder what their experiences with burnout are. We're all kind of sort of burnt out and stretched thin. So in the Q&A, please, if you want to kind of connect your work experience with this, I'd love to hear. But yeah, so much of legacy is also the legacy of being lauded as the first mother-daughter legacy admit, and yet finding yourself, one, back in a sense where maybe your mother once was, but then on top of that, with a sort of further eroded system. So and yet people are still around. You still have the mentors that are still there. You still have the people she worked with who are sort of there to kind of watch out for you, but also now you're in the trenches with them. You're no longer a kid. So what was that experience like? Because it's so enriching biographically, I'm sure, and personally, and yet it must have been such a shock. I mean,
Yeah. I think
besides the lack of sleep.
No, but I would say, but even going back to medical school, so this lauding of us as Black mother-daughter legacy graduate, I am proud of it, because I'm so proud of my mother and everything that she accomplished. But at the same time, I should say, since my sister and I graduated in 2005, there's only been one other Black mother-daughter legacy graduate from Harvard Medical School. And I feel like, in 2024, we're still doing firsts and seconds, and that is shameful. And I feel like a lot of these institutions, they want to pat themselves on the back. And I also want to say, people are like, well, legacy, we talk about legacy admits and all that. I see it as very, very different. This is just like one generation. When we talk about legacy admits, we're talking about multiple generations of privilege. Yeah. You know what I mean? Like, this is just a drop in the bucket. And the fact is that many of us, we go back to work in the same neighborhoods, or we do work in our communities or with our communities. So that's a big difference.
Oh.
And then also, I wanted to say that what I also write about in the book is that there were so many, my mother was brilliant and exceptional, but there were so many other brilliant and exceptional children in her neighborhood, right, that grew up with her. But through a combination of luck, fortune, my mom got to where she got. Yeah. But we know that there's so many other people that should have been where she was.
Right. The year she was admitted to Harvard Medical School, they had admitted 10% of the class was black.
Yes, and that was in the wake of MLK Jr.'s assassination. A lot of institutions had started their diversity initiatives, last affirmative action, and Harvard Medical School had started really focusing. Actually, there were some faculty that got together, Harvard Med School faculty that got together and said, we got to do better. And they actually went to admissions committee and were like, we need to recruit more black students.
And then when you are in the faculty at NYU, there's a class of a handful of black students. What was that like? Like,
no, I know. Yeah,
that?
So I also,
what happened?
I know. I write about in the book how when I was at NYU, there was one of our first year classes only had one black student in there. One. And I write about how the other students of color, they actually were so appalled by it that the students themselves took action and were involved in recruitment activities, and they helped bring in, I think in the next class there was been 25 or 35 students. But I also talk about how one of my students, Natasha, I write about her, she put so much work into these diversity initiatives that the school should have been doing that when she graduated, she said, I'm just so tired. And when she started residency, she said, I'm not doing any of this work anymore. I can't do it anymore. And I think that's also the burden that our students carry, because they should be there for their academic work, but instead they're also there trying to create structural change. You know what I mean? It's a lot. It's a lot for them, and it's not fair.
It's not fair, yeah. Natasha's story actually did stand out to me, and it made me think about where she'll be going. I'm sure she's doing great now, but at that moment of transition of graduating, how harrowing and how worrying maybe, and disheartening. You want to think that a student who's leaving is leaving energized, inspired, and ready to go, and yet we have students leaving weary, fearful, exhausted. So whoa, something's happening. But in your own life, can you talk a little bit about the costs of activism and professionalism, or the sort of the tensions between the two, or the benefits? What have been kind of exciting things that aren't just framed as costs when it comes to that merger?
I feel like I had that experience when I was in academic medicine where I thought I was happy. You're checking off all the boxes. It's a lot. I feel like a lot of people who become physicians do this because it's it's a predetermined path. You kind of, you're going to be pre-med, then you're going to medical school, then you're going to go to residency, then you're going to maybe do a fellowship, so extra training, and then I knew I wanted to stay in academic medicine because I found it very intellectually stimulating, because you get to see patients, do research, teach students and residents. So I love that combination. But what I also didn't recognize was that, I was in a particular environment where I wasn't really able to show up authentically. And I was doing all the work that I thought I was supposed to be doing. And 7 years in, I get appointed to a DEI role in the medical school, and come to find out it's just a figurehead role. And that was very demoralizing to me. And in that role, I was silenced. I really couldn't do the work that I wanted to do. And that's what really drove me to create Advancing Health Equity, my consulting firm. And I ended up leaving academic medicine. I still grieve for that. I still grieve for the career that I could have had. And I think my experience is not a unique one for Black staff and faculty in academic medicine, or in academia.
Yeah, we're 2% on our side of things, so there's not a deep bench at all, despite decades of efforts to make a deep bench. What have you learned from your mentees?
Oh my goodness. I have learned that, and I know this sounds, I don't know, cliche, but that you really have to take care of yourself, and you can't, like I've said before, you can't be a martyr. You can't. And especially like this work is so important that we have to be in it for the long run. So you have to kind of choose your battles, choose areas to focus on, know that you can't, and not to say you have to be an incrementalist, you don't have to be, but also recognize that, you know, you want longevity. I learned so much from Natasha, that like the costs of just of the work. And that no one really is looking out for you. You're looking out for yourself, so you have to really make decisions in your best interest.
And, you know, there's so many things about this that are not just memoir, but still present, I think. You know, COVID-19 and HIV are still very much with us. HIV rates in particular, fast growing amongst Black women here in the United States. Infant mortality rates that are comparable to some parts of West Africa and the Mississippi Delta or Washington, D.C. What kind of American exceptionalism is that? Can you talk a little bit about what lessons we have yet to learn, or maybe what are we ignoring?
Yeah, I mean, I feel like we don't have to reinvent the wheel when we compare ourselves to other high-income nations. You know, in terms of life expectancy, maternal mortality, in terms of how much we spend on healthcare, we are the outliers. And so even looking at maternal mortality, we know that the kind of care model that we have here doesn't support birthing people. We know that there has been a medicalization of the birthing process. And so in the book I talk about, you know, the Shepard-Towner Act of the 1920s that essentially was a public health campaign that portrayed midwifery care as unhygienic and unsanitary, and really made it more difficult for midwives to get their certifications, and essentially led to the medicalization of the birthing process. Out of that act, there were more in-hospital deliveries, obstetrician gynecologists became like the primary clinician for delivering babies. And we've seen the impact of that on the health of birthing people in this country. So we don't have a midwifery-centered model of care. We also know that 2/3 of maternal deaths happen in the postpartum period. And in this country, usually there are 1 or 2 visits at most during the postpartum period. So we're just not as supportive, and we don't support people. And this is not rocket science. You know, for example, in other high-income countries, you are sent, you know, someone comes to your home to check on you. You're sent home with a box including a blood pressure cuff to make sure that you aren't developing preeclampsia. Like, they're really simple interventions that can be done to really improve outcomes, but this just doesn't happen.
And can we talk a little bit about that? Because I think one part of the narrative that I found really interesting was your experience between your first child and your second child in terms of having a doula. And you had the good fortune of being able to interview 5 doulas, all of whom were Black women or black people, and that was a rare thing. One, what are the benefits of having a doula, and then 2, what should birthing people think about when they're interviewing doulas?
Yes, and so I'll just say that for my first pregnancy, I had not even heard of a doula. and a lot of that is just because, I've been educated in sort of a biomedical, the Western biomedical model. And in the emergency department, we end up seeing like the very worst of at-home births. Like we see the outliers. And I would remember seeing, babies coming in that were born at home and hearing the OBGYN team say, I cannot believe they tried at-home birth. Like speaking about the process so pejoratively, when the fact is that most at-home births end up being fine.
Some 89% of people are medically qualified to have it at home.
The majority of first-time births in this country qualify for at-home births.
And some 64% are open to having at-home birth.
Yes.
And yet only 8% or so are at home.
Mm-hmm. And I think a lot of it's because we just don't know what our options are, because of the erasure of midwives. But also, so I learned about doulas in between my 2 pregnancies because I had a traumatic first delivery. And I was like, I need more support. And I was fortunate enough to find a really wonderful doula to assist me with my second pregnancy. But people should know that there's evidence out there that shows that having a doula actually decreases the risk of medical interventions. Because also the thing is, it's the medical interventions like the C-sections that increase maternal mortality. So to have someone there to advocate for you. That's other than your partner. If you have a partner, the partner's there, is very important. And we see that makes a difference in terms of outcomes for both the birthing person and the baby. And then just in terms of what questions to ask is like, how many deliveries have they attended? How many years have they been practicing? Just making sure that you are able to connect with the person, in terms of, just personality-wise, and then speaking to other clients that they've had. And it's really wonderful because they're not just there during the birthing process, it's before, it's post, we can have them postpartum, but part of the issue is that not all insurances reimburse for doulas, right? Same as like lactation consultants. Not all insurances reimburse for lactation consultants. And then also for midwifery care, there's another issue with insurance companies as well, not reimbursing.
So there's a lot more we can do there.
Yes.
And there's like pending legislation as well, right? Do you know about the status of that right now?
You mean for
sort of the 14 or so programs that are being combined to kind of the
Momnibus?
Yes, the Momnibus.
Yes, the Momnibus bill. Yes. Yeah. So that is a bill that kind of has a more multiple components to it, but really has a holistic way of looking at how do we improve this maternal mortality rate. So it's anywhere from training the prenatal workforce, making sure that we have a more diverse workforce, using telehealth, to addressing the social determinants of health. But that bill has been in Congress for like 2 to 3 years, and it's stalled.
Yeah. So it can be moved in the future.
Yes.
So as we come around towards the end to get to Q&A, I wanted to ask, one of the things that really stood out to me in the narrative was your return to your mother's bag, medicine bag, and her stethoscope and all her different diagnostic tools. What was it like kind of thinking with and remembering with the tools of the trade, so to speak? What should we kind of think about when it comes to the tools that we use to diagnose disease? And then I'd like to kind of talk a little about and nerd out a little bit about the present day predicament, I would say.
Yeah, you mean the tools we use today
are problematic and have racial handicaps embedded in them, whether it's the spirometer, which measures lung capacity, where Black people are given a lower average, or
kidney function,
pulse oximeters, or even if it's not a digital tool like the speculum, it has a sort of misogynoirist history. It was invented by a slave-owning person, J. Marion Sims, who was known as the father of American gynecology, whose statue was just up a couple years ago in Central Park. Can you talk to us a little bit about these tools, basically?
Yes.
What do we see? What do we not see?
Yeah, no, so I feel like the tools in my mother's medical bag were like, I feel like I need them. I talk about how I need them as well as, like, our eating utensils, like, because I used to play with them. And I still have her medical bag with the stethoscope and the hammer that we used to test reflexes. But my sister and I used to play with it as a kid, and so, yeah, I feel like, tools, like anything else, can be used for health promotion, but they can also create harm as well. And so I feel like that's like the tie-in to these other tools that we've talked about. And so I don't know if folks in the room are aware of some of these tests and tools that you mentioned. So for kidney function, for lung function, and for vaginal birth after C-section, these these algorithms and these values, they have had a race correction factor associated with them. So, for example, kidney function, based on this myth that Black people have higher muscle mass, and that correlates with kidney function. For a very long time, since the late 90s, there was a different set of normal values for Black patients and non-Black patients. And I talk about how I was taught about that in medical school, but we weren't really given any reason why. We just assumed that this was fact, right? But what we've found out over the last few years is having those different set of normal values has actually delayed referral to specialty care for Black patients. It actually led to them not being placed in the appropriate priority level for kidney transplants. So that even last year, the National Kidney Foundation went back and they had to reprioritize 14,000 Black patients on the kidney transplant list. So we have to think about like how these tools can potentially cause harm. For example, even pulse oximeters, I know probably many of you became familiar with them at the beginning of the pandemic, where you put them on your finger and that you measure the blood oxygen level. Well, it's been known for over 30 years, the FDA has known for over 30 years that that technology is inaccurate in darker skin because it was never studied in darker skin individuals. And it wasn't until a few studies came out over the last 2 to 3 years that showed that people were actually denied medication treatments based on the oxygen level being measured inaccurately. And I didn't even know that. I didn't even know this until those studies came out. Most clinicians don't know this. So you could have a patient saying, I'm not feeling well. I feel like I can't breathe. But they're like, oh no, but your oxygen level looks fine. Right. But it's actually not. Yes. And so there's been a lot of conversations. Actually, about a third of hospitals have gone back and taken out for that race correction factor for kidney function. But it's not mandatory that hospitals do that. There's really no incentive for that. And so that's where I feel like policy, like it should be like if you receive federal funding, then you need to make sure that you're not including the race correction factor in kidney function.
Gosh, yeah, I think a lot about that. The gap between because so I was arrested during Black Lives Matter movement, and I was kept in cuffs for 8 hours, and so I have persistent neuropathies down my median nerve on my left hand. And when I got tested by a neurologist, there's two types of neurologists. There's those who kind of believe your story, and those who just think about what they see on the readout with the nerve test. And this was the latter. He also asked me how did this happen, and kind of gave me a little bit of a judgmental look when I shared why. But it just goes to show, like, you can know what's happening in your body, and you just know that something's wrong, and you might encounter a physician who says, nope, I don't see it. And so this little thing about diagnostic technology, I know it's not the core necessarily of the book, but I just think you show throughout, like, the ways in which we really need to have cultural humility when we're interfacing with patients. And we need to continue to try to find the right answer instead of trying to use the quickness of the profit-seeking model to cut down on the time that we have to consult.
Yeah, no, absolutely. I mean, one thing I talk about is how we need, more patient-centered, ways of caring for people and communities. And yes, you could say you just need to listen better, but I think that bias and racism and other isms are so embedded in our systems that we actually need like protocolized, standardized ways of doing it. So for example, we know there are discrepancies in how pain is treated in patients, there are disparities. So we actually need, our EMRs to keep track of how electronic medical record systems keep track of prescribing habits for clinicians. Is there just, because we know that actually that's how the opioid pandemic started. There were differences, clinicians were over-prescribing opioids to white patients. And not giving opioids to black patients. And that wasn't protective, because we know when pain is not treated appropriately, people have physical, emotional distress. There's an underlying diagnosis that's being missed. Yeah.
We can go on. Can we do a conference, Henry Street?
Yes.
All right. So one last question, and I'll give up the mic and stop talking. But I wanted to ask, there was something that kind of hit me at the end. When you wrote, "We deserve, quote, a life full of wealth and free of debt, given the debts we've already paid." What does that mean to you?
So, when I think about this work that I do, the health equity advocacy work, it really is a matter of life and death, right? When we look at these statistics, it's appalling that in a country with as many resources that we have these just overall disparities. But no one's doing well, but especially Black, Indigenous people are not doing well in this country. And I think about missed birthdays, missed retirement parties, missed graduations, just like lives full of love that are shortened. And that, given the history, especially of Black Americans in this country, and where we are right now in 2024, we deserve so much better. We deserve to live long, full lives.
All right, the mic is yours. Anyone in the audience wish to ask a question of Dr. Blackstock?
Going back to when you were talking about insurance a little bit, I'm curious too, because I think, what I hear is, again, an idea of universal healthcare being a solve for maybe some of these issues. But I guess, I don't know, would that really combat the sort of racism and resegregation that you're talking about? Not to be bleak of things are so broken, but I'm just curious if what systemic level changes could really, change, what do you see as some options that could really make changes to those?
We're gonna start sharing this now. Well, my quick answer is always been about resources in terms of staffing levels. So you can have all the beds in the world, but if you don't have enough nurses and social workers and all the people that make a hospital run, what's the point? So it always goes back to sort of our ethic around labor in this country, labor rights in this country. I do believe, professionally, yes, you need to stand up for yourself and individually protect yourself, but we're much stronger when we have strong unions, when we have strong workplace protections, when we have sufficient staffing levels that are mandated so that you can't just shortchange the limited number of nurses that remain. But something that legacy taught me too is that it's not only important to have sufficient staffing levels and beds and all these things, all these resources, all the paraprofessional and professional resources in place, but the concept of racial concordance between the patient and the doctor also matters, right? So much of the COVID-19 stories in this book are of older Black Americans who are suspicious of interfacing with white physicians. And what does that cost? If you're so fearful to work with someone who could cure you or heal you, and you're not quite sure whether you're going to get the right kind of treatment, we might want to think a little bit more deeply about the composition of our workforce and whether it matches the communities that they're serving, right? So thankfully we have people like Dr. Blackstock who are willing to take prestigious degrees and go back into public hospital work, but that's not usually what happens, right? And so for the small sliver of professionals who do make it into, Black professionals, brown professionals, who do make it into doctoring, so many are debt-ridden, so many can't make the same choices, and so they're not returning to those communities. And so we need to kind of solve the medical debt crisis too. Luke Messak has written an excellent book about the medical debt crisis. And I think we have a growing awareness now that medical debt is also a big issue. So I'll pass it over to you.
People, I think, go bankrupt. Yes. Yes. So I have a lot to say about your question. Yes, I think we know that access to healthcare and quality healthcare is very important. And yes, I think racial concordance is important. Everything that George said is important. But I also want us to have, and I think everyone in this room would agree, like a holistic idea of what health looks like. And I know I mentioned this before, but really this understanding that what happens on a community level for people is what impacts their health the most, right? And so I think that's why the work that you all do is so incredibly important. And when I was looking at the website and all the programs that you have, I'm like, yes, all of this is directly related to good health. And when I think about the legacy of redlining, we can look at multiple cities, and that when we look at formerly redlined neighborhoods, and ones that haven't been gentrified, we see those are the ones that have the highest chronic disease rates, the highest asthma rates, the highest maternal mortality and infant mortality, right? So we look at neighborhoods that have been chronically deprived of resources also have poor health outcomes. So I love thinking about what can we do on community levels to make them healthier. What are the myriad of ways that we can do that? Oh, and I also just want to say, yes, that for Black patients and patients of color, that racially concordant care is important, but I would love for us to have a system where any patient can see any clinician and get the best care, right? Unfortunately, that's not the case. But I think obviously working towards a more diverse workforce and thinking about this debt issue, because the racial wealth gap is profound in this country. And I know folks, we may have heard about some medical schools that have received large donations and have tuition-free, are now tuition-free. I am very wary of that because, like we've seen actually with NYU, it's tuition-free, but what happened as a result is it actually became less diverse and more competitive. So they received even more applications, but instead of kind of looking at these applications through a lens of equity, right? Because not everyone, 40% of my class at Harvard Medical School were paying cash money for tuition. So when you look actually at even who goes to medical school, there are huge disparities in terms of socioeconomic status. Like 40% come from the top quintile. So when I hear about these tuition-free efforts, I also want to say, well, okay, so what are you doing in terms of the admissions process to make sure that you are, giving these resources equitably to students who need it? Because someone who is like fifth-generation physician whose parents have a lot of generational wealth compared to a first-generation person, they need different resources. And if you're going to, the whole point is to make sure that you're addressing the needs of each applicant or student.
So first, I want to say thank you and just highlight the fact that it's always motivating to have representation at the levels that you guys are, and being able to use your platform to voice the concerns and the plight of those who don't have voices to do so. So thank you so much. There was so much emotion that I experienced just sitting through this. As a clinical social worker, I know the intersectionality when we talk about health disparities and the social injustices and how that shows up. But I appreciate the fact that you really highlighted that burnout piece and how important it is to understand that you don't have to feel guilty for saying I can't be the only one doing this. And instead of just burning out and being quieted, you pivoted. and continue to do the work in another space. And so being able to find a lane and kind of stick there and still have the message be told and people hear your voice, super important, because how many people just like stop because they just can't go anymore because your back is broken? And I heard this saying a long time ago and it never left me, which was like, check on your strong friends. At some point, you have to stop moving and you have to rebuild, right? Like, you can't continue to carry the weight of the world, and it happens so often, and then we just break. Yes. And then the work stops, or it could stop, but to know that there is a space for you to pivot and continue to do the work that is needed, and sometimes it can't be everything. You gotta pick that one thing and just be great at it. So thank you.
Thank you, thank you.
Shout out to you, because that's a transition to my question. I appreciate you. The burnout piece is definitely something that stuck with me in hearing your story. And I work as a youth development chair with my youth, specifically talking about burnout this fall, of just understanding priorities, understanding limitations, and understanding the power of choice that you bring into the space. And as I'm sure all of us here are advocates in this community and have to not only deal with but nurture our own burnout, how do you implement burnout preventative strategies in spaces that are needed most because of the advocacy that is brought from those spaces?
That's a challenging one. I will say this. When I founded my organization, I had an external mission, like what the work that I wanted to do, but I didn't recognize that in creating my own organization, I was creating an environment, a work environment that was the one that I needed. And so a lot of our team members will say, they're like, we just love working here because, one, we feel like you care about us, that we can show up as our full authentic selves, that we can have boundaries. And so, I think that we need folks in leadership positions to understand that again, burnout is not an individual issue, but a systems issue. And how can we have folks like you be able to do your work, but also not get exhausted? And so I feel like for me, by creating my organization, I inadvertently did that. I didn't realize I was going to do that, but I kind of learned along the way. I was like, okay, wow, I'm actually created the organization that I needed for myself. I wish I had something better to say.
Well, we should go ahead and wrap up. Thank you so much for this conversation, and thank you for being here.
Thank you. Katie, can I just say one thing?
Of course.
We didn't get to talk about the Flexner report, but I just want folks, if you get the book, to make sure you read about the Flexner report, because in terms of history, that is the report in 1910 that led to the closure of a good number of medical schools, but it led to the closure of 5 out of 7 of the historically black medical schools, leaving behind Howard and Meharry. And it's estimated that if those 5 medical schools had remained open, they would have trained between 25,000 and 35,000 black physicians. So essentially thinking about just the history, the domino effect of organizational policies, and how the impacts of numbers we see today, because less than 6% of all physicians are black. And it's not because there's anything inherently wrong with us, it's because of policy violence, like the Flexner report. So that's a little bit of history that I hope you all will read about.
Thank you. Please pick up the book. We have it right over here. And again, it's being sold by You and Me Books, which is a local Lower East Side bookstore. Thank you so much for being here, Henry Street staff and the public. And thank you to our speakers, Uche and George. Thank you so much.